The last chapter, actually, it's not in your book. Isn't a chapter that's in your book. It probably should be in your book because of the serious problem they're having with the opioid crisis. Of course, we talked about opioids, but many people, there are lots of people dying from opioid overdoses, and a lot of these are prescribed pills. So we're going to talk about pharmaceuticals today. We're going to talk about the pharmaceuticals that you may potentially come in contact with. Some of these are older pharmaceuticals, but I think it's really important for you to understand that some people do not respond to the newer treatments, and so they have to go to older and older treatments. We're still using things like electroconvulsive therapy, which is really an old idea, and we're not exactly sure why it works. But we're going to talk about pharmaceuticals today. It's really kind of curious when you get into this into counseling, if you go in that direction. One of the things that will happen is that your clients or your patients, however you want to look at them, let's call them clients. Your clients are going to be on medication of one kind or another. And it's important for you to know what we're talking about, how strong some of this stuff is, um, when it was developed, how old it is, how much efficacy it has. When A good example is when Prozac first came out, it was really popular, and they were going, "Oh, good, we can get them off these other horrible uh, antidepressants that had all these side effects. Good, we can put them on Prozac." And in the beginning, they said, "Wow, it's got 90% effectiveness." And then, more and more studies came out, and more people weren't responding to it. So they said, it's closer to 75%. Then went down to 65%, and 60%, and yeah, we're hitting at about 50% right now. But there are other medications out there. There are other pharmaceuticals that you can take, other SSRIs that you can take that have a little bit different configuration that potentially might work. So we're talking about pharmaceuticals today. We're talking about things. These are our names that you may hear in the future. I'll try to use the names that you'll probably hear. Um, Sometimes doctors, when they're around their patients, instead of saying Prozac, they'll say fluoxetine, and that way they're if they're it's kind of like a code, okay? You can use the chemical name, or you can use the generic name for it. So if you actually the generic name for Prozac would be fluoxetine. So yeah, every pharmaceutical has three names. One is the chemical name, one is the pharmaceutical name, and the other one is the marketing name. So Prozac is the marketing name. Um, Fluoxetine is a pharmaceutical name, and I can't. It's like fluoxetine hydrochloride or something. Um, is the chemical name. But all pharmaceuticals, you have to deal with all three sometimes. The pharmacy will talk about the chemical name, and the doctors probably will talk about the pharmaceutical name, but you know it as its common name, or its marketing name. I mean, if you call it fluoxetine, they get it mixed up with all these other chemical structures. So this is really kind of an interesting chapter. I didn't put this together. This was put together by a medical intern. Doctors, pharmaceuticals change so rapidly that doctors don't really study pharmaceuticals because by the time they get out into practice, the names will have changed, and they need to know what is best and what is on the market right now. They were having problems with this back in the 70s, 80s, and 90s. So Congress decided that they wouldn't let pharmaceutical companies um, they were giving doctors trips, and they were to learn about this new medication. They were sending them to Hawaii, and then of course when they came back they felt like they obliged to use that pharmaceutical, and this was happening over and over again, and they were having some problems with select pharmaceuticals. I know Abbott had a problem with Biaxin. You can't find it on the market anymore because it doesn't really work. It was an antibiotic, and that's and Congress got involved, so they decided not to do that anymore. And for that reason, why am I talking about this? I can't remember. I've lost my train of thought. Anyway, so what we're going to talk about today, we're going to start out with SSRI antidepressants, selective serotonin reuptake inhibitor antidepressants. Then we're going to go to the atypical antidepressants, SNRIs. Then we're going to talk about some of the historical antidepressants, tricyclic antidepressants and monoamine oxidase inhibitor antidepressants. Then we're going to talk about mood stabilizers for bipolar disorder. Then we're going to talk about antipsychotics, and then benzodiazepines, stimulants for ADHD. Then we're going to talk about medication for dementia, meds to treat substance abuse, and last but not least, medications for anti-blood pressure medicines, the antihypertensives. Why are we doing this? Why are we doing this? Because when you get out into the game, you're going to hear all these names. You're going to hear a lot of different names of pharmaceuticals, and it's good to at least be aware of, hey, wait a minute, that's used to treat depression. Why is this person on this antidepressant when they're treating them for anxiety or whatever, or it'll be somebody. What happened to where was I? They were using an antipsychotic as an antidepressant. And I couldn't figure that one out. It just didn't make any sense to me. Well, what was happening, they were treating them for depression, but it was depression because of substance abuse. And the only way they could control their substance abuse and their depression was by giving them an antipsychotic. And that was a new type of treatment that they were using at that time. I don't know if they still use it, uh, because I'm not privy to that kind of information. But pharmaceuticals are really tricky because doctors will give you whatever seems to work for you, and pharmaceuticals don't always work for everybody. It's like the Prozac. Prozac in the beginning, they thought it had 95% of efficacy, and then they found out it only had 75% efficacy, and now it's down closer to 50%. Some people, things don't work on. Opioids don't work on me. It doesn't do anything to me at all. Rats. I can't take away pain with opioids. I can't take ibuprofen. If I take ibuprofen, it makes me depressed. So everybody's different. I mean, everybody's biochemicals are different. So that's one of the things you need to know about pharmaceuticals. So we're going to talk about pharmaceuticals today. Why don't we go ahead and get started? And I'll stop mumbling around my last lecture in this class, and we'll go right here. There we go. Like I said, I stole this from a doctor. I tried to clean it up because, he was talking about, what did he talk about? He only used chemical names, which is fine for doctors, but you guys don't need you don't need those chemical names. You need the common names, the marketing names. So that's what I've tried to use. SSRI, selective serotonin reuptake inhibitor antidepressants. The mechanism of action for SSRIs, selective serotonin reuptake inhibitors inhibit serotonin reuptake, so that they increase synaptic serotonin levels. Many SSRIs affect other receptors, especially at high doses. SSRI's clinical effect usually takes weeks, so the mechanism goes beyond simply increasing synaptic serotonin levels. There are several serotonin receptor subtypes, and this is actually the chemical structure of serotonin. This is what they call it, 5-HT. So if you see 5-HT in literature or 5-HTTT, what they're talking about is serotonin. All right. Serotonin receptors are located throughout the body, especially in the GI tract. I'm not sure why that's there. Wait a minute. Okay, wait a minute. It's still there. It's in the GI tract. Lots of so you get happy in your gut if you think about it, because there are a lot of serotonin receptors in your intestinal tract. Indications of off-label uses: all SSRIs, including Luvox, are FDA approved to treat depression. This is not only major depressive disorder, but what we used to call dysthymia. Dysthymia is the blues. It's low-grade depression, but it's chronic. And that was called dysthymia. They took it out of the DSM-5. It was in the DSM all the way back. It's been in the DSM one through 4 TR, but it's not in the DSM-5. And we do this from time to time in psychology. We decide we're going to take a term out of the parlance of psychology. And that's what they did with dysthymia. But the meaning of dysthymia is the blues, pretty much, chronic blues. Various class members of SSRIs are also approved to treat generalized anxiety disorder, OCD, panic disorder, PTSD, eating disorders, premenstrual dysphoric disorder, and social anxiety disorders. So SSRIs are used all over the place. It's also used as a maintenance drug for bipolar disorder. So they will treat them with the heavier antipsychotics, with the mood stabilizers, plus the antidepressant, plus the SSRIs. Off-label uses: ADHD, insomnia, chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia, and intellectual disability. It kind of numbs them a little bit and allows them to be more socially functional. The half-life, the half-life is short, moderate, and long. For somebody taking the dosages that are short, these individuals, if they miss a dose, it can be a really serious problem because they start having side effects. So the missed doses have an uncomfortable side effect. Paxil and Luvox have a short half-life. Moderate half-lives: Zoloft, Celexa, and Lexapro. And the ones that you really don't have to worry about missing a dosage of the SSRIs, Prozac. It takes about 6 weeks for it to start working. It builds up in your system, and you don't have to worry, oh, geez, I forgot to take that pill today. You don't have to worry about that with Prozac, because Prozac has built up in your system, and it takes about 6 weeks to get it out of your system, actually. For the moderate ones, if you miss for a couple days, or you forgot your pills over the weekend, by Monday you're going to be in trouble. But the short ones, the short half-lives, you miss one pill and you're SOL. It's not a good thing. Side effects of SSRI antidepressants: decreased sex drive and impaired sexual function, tend not to be resolved with time. So a lot of things, it'll take care of that problem over time. Nausea, a lot of times, will decrease. But the sex drive thing doesn't go away. And this is because your sex drive is produced by testosterone in your hypothalamus, whether you're male or female, and it's controlled with serotonin. So the serotonin, balances your sex drive so that you're not, jumping on people and trying to have sex with them all the time. And what does that, what makes you socially acceptable, is serotonin. And so if you increase the serotonin level with SSRIs, where the serotonin obviously is more abundant in your hypothalamus, in your brain, then your sex drive is going to suffer from that. It's not going to be as strong as it was before. It may not be there at all. That's your libido may go completely away, and that is one of the side effects of SSRIs. Not all of them. Some of them aren't as bad as others, but Prozac especially, um, Paxil. The Zoloft is theoretically not as bad, but I've had people complain about their sex drive going away with Zoloft too. There are some that have no sexual side effects, and that's because they do other things than affect your serotonin level. Nausea, diarrhea, anorexia, vomiting, all these increase with dose but will be resolved in time. Weight gain, especially Paxil, paroxetine is the chemical name for the pharmaceutical name is paroxetine for Paxil. After initial GI effects, you will gain weight. In other words, you vomit. You may react with nausea and diarrhea and vomiting, but it goes away in time, and all of a sudden you start gaining weight. Headache, dizziness, anxiety, especially with Prozac, which is fluoxetine, as I was saying before. Rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially with Paxil, paroxetine. Bruising, increased prolactin, which is the protein that enables females to produce milk. Drug-to-drug interactions, Luvox increases Prozac, increases Paxil, increases Zoloft, increases Celexa, increases Lexapro. So if you take Luvox and you take another antidepressant with it, then it's probably going to increase the effect. The interacting effects can be dose dependent, as with Zoloft. SSRI levels tend not to be altered by other drugs, but can potentially increase levels by inhibiting metabolism of certain drugs. So you need to be aware, your doctor needs to be aware of the fact that there is a possible interaction taking place between an SSRI and whatever else you're taking. Examples, Paxil will increase buspirone, which is an antipsychotic. Prozac will increase buspirone, which is an anxiolytic, an anti-anxiety drug, and Luvox will increase olanzapine, which is a antipsychotic. So you'll have an increased reaction to those. Caution, suicidal ideation and increased suicide risk, especially with children early in treatment, but there is significant debate about this. There have been suicides because it takes away your inhibitions. So that's one of the reasons why we rarely give SSRIs to children. If we do give it to children, then we make sure that the parent or guardian is aware that this is a possibility and that they need to watch them, talk to them from time to time about suicide. Because if you talk to them about suicide, then you're thinking, well, it puts the suicide in their mind. But the reality is, it puts them on alert that you are aware that if they have suicidal ideations, that you are going to become aware of that. Serotonin syndrome, SSRIs plus any MAOI, possibly lithium can cause serotonin syndrome. This is really serious stuff. Serotonin syndrome is diarrhea, tremor, sweating, and this is progressive, as you can see. Diarrhea, tremor, sweating, restlessness, hyperreflexia leads to a progression of symptoms if untreated. If you're on any of these SSRIs, you need to be aware that serotonin syndrome is a possibility. It causes disorientation. Then it moves on to rigidity. Fever leads to coma. Seizures, of course, during the coma leads to death. And it has a 10% mortality rate. So, any negative reaction to serotonin, to the SSRI, you need to talk to your doctor about it, because they certainly don't want you to die under their care from something that they could have kept you from having. Many medication substances have serotonin activity. Dextromethorphan, which is a cough medicine, has increases the serotonin level, and that's one of the reasons why people use cough syrup, cough medicine, to get high. It was a club drug there for a while. People would go out on the dance floor and chug a bottle of Robitussin or whatever. Fentanyl can act has serotonin activity, increases your serotonin, which is one of the reasons why it can be deadly, because it has a sedating effect. And Of course, the opioid itself has a sedating effect, but the increase of serotonin may cause uh, uh, a fatal amount of respiratory arrest. Meperidine, which is an opioid commonly called Demerol, also can be a problem. Somatriptan, which is a migraine headache medication. Don't you can't take these together. St. John's wort, which is an herbal antidepressant. It's very popular in Europe. They use St. John's wort as an antidepressant. They will use St. John's wort, and if St. John's wort doesn't make you less depressed, then they will start using SSRIs, and then if that doesn't work, they'll move to something else. But St. John's wort is usually the first line of defense against depression. MDMA, ecstasy, actually, and LSD, they both increase your serotonin levels. So if you're already on SSRIs, then taking ecstasy and LSD probably not a good idea. Actually, dealing with any of this stuff, if you're on an SSRI, don't do it. Citalopram or Celexa has few drug-to-drug interactions, high serotonin specificity. It's typical or less SSRI side effects. That's Celexa. Lexapro, no, there is no generic available for Lexapro. It has simple dosing. Fluoxetine, also known as Prozac, of course, and those are all other names for Prozac. Seraphim, Symbyax with Zyprexa. Very long half-life. That's one of the reasons why we use uh, Prozac for people that forget to take their medication. So there is significant drug-to-drug interaction, and it's because it stays in your system for such a long period of time. Fluoxamine, Luvox, it's used to treat OCD. It has multiple significant drug-to-drug interactions, so you got to be very careful. This stays in your system for an extended length of time as well. Paroxetine or Paxil has significant drug-to-drug interactions because it raises your serotonin level so high. Some reports have associated weight gain, withdrawal symptoms with missed doses, so you need to be careful with Paxil. Sertraline, Zoloft has a moderate drug-to-drug interaction. It has a multi-step dosing, so at the higher dosages, you can have a serotonin problem. Atypical antidepressants, these are usually SNRIs, newer antidepressants that are not or less serotonin specific or affect serotonin differently than SSRIs. These are the atypical antidepressants. Desaril or trazodone. Desaril is an anti-PTSD medication. It kicks you into REM sleep faster when you go to sleep, so that you don't ruminate on bad dreams or whatever. Wellbutrin was developed in 1981. Remember, Vietnam War ended in 1975. We had a really serious problem with PTSD. About a third of the combat veterans coming back from Vietnam, and non-combat veterans were suffering from PTSD, and for that reason they developed Desaril. But people don't like it because it makes them feel dull. 1989, Wellbutrin or bupropion was developed. 1993, Effexor. 1994, Serzone, Nefazodone. 1996, Remeron was developed. Mirtazapine. 2004, Serzone was discontinued, although generics are still available, mostly in Europe and Canada. Something to stay away from. It was discontinued for a reason, and they were having difficulty with it. But of course, the Europeans, the Canadians feel like they have more control over this stuff than we do in the United States. A lot of Americans don't take their medication properly, and that was the problem. 2004, duloxetine or Cymbalta was developed. Mechanisms of action of the atypical antidepressants. Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors, SNRIs. Remeron has a serotonin subtype and norepinephrine activity. Trazodone and nefazodone have different serotonin activity than SSRIs. Bupropion has dopamine and norepinephrine activity, and that's why it works as an antidepressant, because it increases your norepinephrine and your dopamine levels. Indications of off-label use. All atypical and typical antidepressants have FDA approval to treat depression. SNRIs have been shown to be effective in chronic neuropathic pain. Wellbutrin has been approved to treat nicotine addiction. Wellbutrin can augment SSRIs to reduce SSRI sexual side effects. Wellbutrin, of course, doesn't increase your serotonin level. Remeron and trazodone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical SSRIs. Wellbutrin, Remeron, trazodone, and nefazodone do not usually have associated sexual dysfunction. And for that reason, a lot of people want to go off the Prozac, Paxil, and Zoloft and use something that doesn't increase their serotonin level, that doesn't have sexual side effects. You can imagine, with all the depressed people in the United States, if all of these people were on Prozac or Zoloft or Paxil, then that's like what is it? Between 6 and 10% of the population at any one time are suffering from depression. That's 6 to 10% of people that are potentially non-reproductive at that point. Effexor is similar to tricyclics with less safety and side effect concerns. We're going to talk about tricyclics later. That's next, actually. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. As an SNRI, Effexor activity depends on dose. Effexor has a minimal drug-to-drug interactions. Effexor has side effects with missed doses. And I know that because my wife was on Effexor. I went on a Fulbright trip to South America, South and Central America back in 2003, and I was gone for 6 weeks, and this was 6 weeks during the summer. The semester had just ended. You know, I really get into my teaching, so she was looking forward to being around me when I wasn't teaching, I got on a plane and took off for South and Central America. I was gone for 6 weeks. And during that time, she became depressed because, well, wouldn't you become depressed if I wasn't around? Anyway, she became depressed, and she started and she was starting to have anxiety. Maybe it was the anxiety more than the depression. Anyway, we lived out in the middle of nowhere in Montana, uh, and we don't. I don't believe in security lights. So here it was dark, and of course she's from the city. Anyway, she got depressed, and she started having anxiety problems. So she started taking Effexor, and she was fine. I got back, and I picked up a parasite while I was down there. Not that that's important. Anyway, so after about a year of being on Effexor, she decided she wanted to go off because she was having it was increasing her hot flashes. She was in her late 50s at the time. And so she decided she would go off of it. And in order for her to go off of it, she decided instead of going cold turkey, which is really painful as far as Effexor is concerned, she decided that what she would do every week, she would break open her capsules and take one less, you know, uh, ball of medication. So she counted them all out, and one week she took 30, and the next week she took 29, and then 28, 27, and it worked. She was able to get off of it. So there you go. That's my story. At one point, she got on a plane and she forgot her Effexor. This is when she was still taking it. She forgot her Effexor, and she was in, I can't remember where they went. I think it was Seattle or Las Vegas or someplace. It was a DAR convention, and she forgot her medication. And so she started having the nausea and the vomiting. And her roommate, they're all older women. They were, it's a DAR convention. And when Karen told her what the problem was, she said, "Well, I've got some." So she gave her Effexor. And that's all the stories I have about Effexor. Duloxetine, Cymbalta. You may have seen commercials on television about Cymbalta. They want you to add this to your antidepressant. If you're not having a good effect, you're not getting a good effect from your Prozac or Zoloft or whatever. Cymbalta is an SNRI that has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion, also known as Wellbutrin and Zyban, is a norepinephrine and dopamine reuptake inhibitor. Zyban is used, of course, to treat smoking addiction. Bupropion is a seizure risk in certain patients, increased risk at high dose. Bupropion's drug-to-drug interactions are not often significant except with MAOIs. And what we're going to find out is that if you're taking an MAOI, you got to stay away from everything. But some people, their depression only responds to MAOI, so they have to take it. One of the things about bupropion is that gaming addiction, they're starting to treat gaming addiction with bupropion. And of course, we don't recognize gaming addiction in the United States, but in Asia they are. And of course, that is the medication that is the choice in Asia as far as gaming addiction is concerned. Really serious problem with gaming addiction in Korea, Taiwan, Japan, and China. So this is a real serious problem. Mirtazapine, Remeron, mirtazapine is a complex serotonin that has norepinephrine, alpha-2, and histamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has sedation and weight gain, especially at lower dose. Mirtazapine usage can have lipid abnormalities, and this is one of the things you have to be careful of. You have to have your blood drawn to get your lipid levels from time to time when you're taking mirtazapine. Otherwise, you're going to clog up with LDL. Remeron has minimal drug-to-drug interactions except with MAOIs. Nefazodone or Cerazone is rarely used due to irreversible liver toxicity. Nefazodone was pulled from the market by initial manufacturer in 2004, although it is still available as a generic. In other words, you can still get it up in Canada. Nefazodone is still popular with some patients because it worked for them. And just like I'm not sensitive to opioids, I'm like one of 5%. I'm a member of that 5% of the population that doesn't respond to opioids. Some people just don't respond to things. They're different. Their biochemistry breaks it down too early or whatever. Trazodone or Deseril, it causes sedation, weight gain, and low blood pressure. Trazodone is used most commonly off-label for insomnia. The insomnia that we're talking about is the insomnia from PTSD. People don't want to fall asleep because they're afraid they're going to have recurring dreams of their trauma. Rare reports of sustained painful erection, priapism, that should be treated in the emergency room. It can lead to impotence, has been reported with trazodone. So what are we talking about here? What's wrong with having a constant erection? What's wrong with it is that it causes vascular damage in your penis, and that's a real serious problem. That vascular damage, that expanded vascularization. Now all of a sudden you're not able to have an erection because of the vascular damage. That's the problem with priapism. Tricyclic antidepressants describe a group of drugs with similar structure and function. They're abbreviated as TCAs, tricyclics. Imipramine, in 1958, imipramine failed investigation as an antipsychotic, but it found to have antidepressant properties. Before 1958, we didn't have much to treat depression with, but then they invented the tricyclics, and everybody was happy. 1960s, multiple other TCA tricyclics developed and placed into use, and as you're going to see, any of the amines and tylines, these are all tricyclics. In 1990s, significant reduction in use due to introduction of SSRIs, which had fewer side effects than the tricyclics. And we're going to talk about all these side effects from the tricyclics and the monoamine oxidase inhibitors. The mechanism of tricyclic antidepressant action, there is norepinephrine, serotonin, histamine, muscarinic, and alpha adrenergic receptor activity in differing ratios. So as you can see, it increases a lot of different things. And some people who serotonin isn't that important for them, they need the norepinephrine, histamine, and muscarinic and alpha adrenergic receptor activity to keep from being depressed. Anticholinergic activity leads to many of the side effects of these drugs. It is used for depression and similar spectrum disorders as SSRI. Tricyclics are especially helpful with chronic pain and depression secondary to medical conditions such as AIDS. Side effects include, one of the things about, if you take a tricyclic, if you're depressed and you take a tricyclic, it'll get into your system right away and the depression is alleviated to some extent. If you take Prozac, it's going to take 6 weeks for that stuff to get into your system, for it to build up in your tissue, for the depression to go away. So this is one of the reasons why sometimes Prozac isn't the drug of choice. Side effects include enuresis, wetting your pants, narcolepsy, premature ejaculation, insomnia, and migraine prophylaxis. In other words, it stops migraine headaches. Can't argue with that. Blood may be obtained to monitor dose effectiveness, and of course, that is one of the things. That's one of the reasons that I first came and became involved in dealing with tricyclic medications. I was a laboratory technician, and I was drawing uh, uh, dicipramine and imipramine and all of the rest of the amines, nortriptyline levels on individuals that were taking the antidepressant. This is way back in the 70s. The SSRIs were invented until the 1990s. So before the 1990s, people were taking, they were probably taking tricyclics, and it can damage your liver. So this is one of the reasons with what was going on back in the 70s. It's one of the reasons I became involved with dealing with it. We were drawing blood levels. Drug-to-drug interactions for tricyclic antidepressants. Tricyclics have multiple significant interactions in each direction with potential serious consequences. Side effects of TCA of tricyclics for anticholinergic problems include dry mouth, constipation, blurred vision, and urinary retention. Cardiac arrhythmias and conduction changes, orthostatic hypotension, sedation, weight gain. Cautions when taking tricyclic antidepressants. Overdose is frequently fatal. Patients with bipolar disorder may be pushed into mania or rapid cycling. This is one of the reasons why I was drawing serum levels on these individuals, trying to make sure that it hadn't built up in their tissue to the extent that they may have a fatal overdose. And that is a possibility. Now, the problem is with the individual taking the medication, they're feeling happier and happier and happier. So, as far as they're concerned, this is a good feeling. This is a good thing. But as far as the doctor is concerned and their body is concerned, if they build up that much of a level in their bodies, then it may become a fatal overdose. And of course, so if you're happy and then you're real happy and you're really happier even more, that's mania. Amitriptyline or Elavil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine and is high in pain control. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. Remember, we said that it has anti-migraine effects. So you can use this antidepressant to treat people's migraine headaches. Amoxapine or Ascendin is high in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Amoxapine works as an antidepressant rapidly in about 1 to 2 weeks and has been used as an antipsychotic. Clomipramine or anafranil is low in norepinephrine activity. It's high in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and it's high in pain control. It's used to treat OCD, depressive disorder, panic attacks, and anxiety. Now, you may wonder why in the world I am so familiar with all of these things. And the answer is because I worked in medicine for 30 years. And I came in contact with some of these, and because of that, I heard how you pronounce the words. Now, as we get on into the chapter, I didn't really deal with antipsychotics very much, and for that reason, some of the antipsychotics I don't pronounce very well. Clomipramine, anafranil, Ascendin, Elavil. I've heard all of these terms a lot and pronounced properly. And there's always a question as to whether you're pronouncing any of these medications or any of these words, these difficult words, properly. But because I've heard them over and over again, especially the tricyclics, because we were drawing the blood levels in the lab. Because of that, I've already seen all these words. Dicipramine, norpramine, actually dicipramine, I've seen that a lot more than norpramine. Norpramine is a high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects. It blocks acetylcholine, and it's low in pain control. So potentially, if we're dealing with a fairly young individual in their 20s and 30s, we want to give them something that's low in serotonin activity because we don't want to take away their sex drive. Elavil is low in serotonin activity. Ascendin is low in serotonin activity. Anafranil is high in serotonin activity. So we wouldn't give anafranil to somebody in their 20s and 30s, probably in their 40s. It would have to be somebody that's a little bit older, or somebody that's suffering from really serious OCD. Dicipramine is used as an antidepressant and to treat ADHD. Doxepin or Sinequan is low in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and it's low in pain control. Doxepin is used to treat major depressive disorder, anxiety disorders, chronic hives, and insomnia. Now you can imagine that if you're treating somebody with a tricyclic and all of a sudden they have no sex drive, they're going to come in and complain. You know that that's going to happen because they're going to start having problems with their significant other, whether it's male or female. They're going to start getting complaints that they don't feel like having sex, or you're going to get the spouse coming in and complaining that what the hell did you give this person? So you can imagine what's going on. Imipramine or tofranil is low in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and moderate in pain control. Now, one of the problems with blocking acetylcholine is that acetylcholine is how you remember things, is the neurotransmitter in your brain that allows you to remember things. So potentially, some of these that block acetylcholine, potentially you're going to have memory problems. Oh, wait a minute. Tofranil, we're still talking about the tofranil, used to treat depression, anxiety, and panic disorders and enuresis. Meprodoline or Ludamil is high in norepinephrine activity. It's low in serotonin activity. It is low in anticholinergic effects and moderate in pain control. So, I'm going through all of these things and you're going, like I care. Well, if you were treating somebody with any of these tricyclics, you need to know how much serotonin is it, increasing the serotonin to the extent that this individual is not ever going to want to have sex. Is it blocking acetylcholine so that they'll start having memory problems? This is all the stuff that you need to think about. Meprodoline, of course, you're not going to be prescribing any of these medications, but you're going to be hearing about all their complaints. I can assure you, you'll be hearing about all their complaints. Meprodoline, Ludamil is used to treat depression, anxiety, panic disorder, and neuropathic pain. Nortriptyline, this is a real popular tricyclic, Pamelor. It is a moderate in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects, which means it kind of bothers your memory, and it's moderate in pain control. Nortriptyline is used to treat depression, and it's an anti-anxiety drug, ADHD, neuropathic pain, and to help in smoking cessation. Protriptyline or Vivactyl is high in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects, and it's low in pain control. Protriptyline is used to treat depression, ADHD, and its energizing effect is used to treat narcolepsy. Trimipramine or Sermontil is low in norepinephrine activity. It's low in serotonin activity. It has high anticholinergic effects and high in pain control. Trimipramine is used to treat depression, anxiety disorder, psychosis, and insomnia. Okay, now we're going to talk about the monoamine oxidase inhibitors. This is really troublesome. This stuff you can't take anything that increases your serotonin. You're going to have an adverse reaction. You can't take tricyclics with monoamine oxidase inhibitors. You pretty much can't take any other medications. It's really dangerous stuff. This monoamine oxidase inhibitor. So you may be asking yourself, why in the hell would they ever come up with a medication that is so dangerous that you can't take anything else with? And the answer is because some people only react, their depression only is alleviated by monoamine oxidase inhibitors. And it was also one of the first antidepressants that was developed. In 1952, the first MAOI found with antidepressant properties in a process of looking for an anti-tuberculosis medication. So the pharmaceutical company that discovered this stuff was actually looking for a medication they could use to treat tuberculosis. Well, it worked as an antidepressant. It works really well. It's a very good antidepressant. The problem is there are some things you can't eat, and there are medications, a lot of medications you can't take. 1962 investigation of a death from hypertensive crisis by someone ingesting tyramine-rich foods while taking an MAOI. So we used it for like a decade, and probably we had other hypertensive crisis with other individuals taking it, but we didn't recognize it as a drug interaction with MAOIs. But then we realized, yeah, it probably is. We need to start restricting people's diets. That happened in the 60s. In the 1960s, significant reduction in use due to introduction of tricyclics. They became popular in the 1960s. And of course, if you were on MAOIs, you got a real serious problem. In 2006, they came up with the transdermal selagelene patch MSAM to treat depression, and it has MAOIs in it. But if you're taking MSAM, if you've got an MSAM patch, you better not take any other medications, or you're going to be in trouble. The features of MAOIs. MAOIs are an effective antidepressant for those who can adhere to the necessary restrictions and tolerate many of the other side effects. Very long duration, requiring caution with mixing with restricted substances or medications. Now, the reality is you can eat some of these tyramines. You can eat some of them as long as you do it in moderation. It's okay. If you get a little bit too much, you have 3 hot dogs instead of 1. Now you're going to have a reaction, and the reaction is ugly. The reaction is high blood pressure to the point that it kills you. It gives you a stroke. So these are the tyramines. These are the things that you need to stay away from: cheeses, chocolate, soybeans, hot dogs, dry sausage, jerky, caffeine, beer, wine, pickles, and olives. All of these are processed foods. Because they are so processed and they have tyramine in them, then you need to stay away from them. And it's tough. It's pretty tough. You need to be aware of all the food that goes into your system. Almost all cheeses are fermented. Fermented milk is what it is. You can't eat any jerky. You can't drink any beer or wine. No spirits. You can't drink a Mountain Dew. You can't drink coffee. You can't drink tea. Anything with chocolate in it, you're SOL. You got to stay away from just a lot of different things. And most people don't like that. Drug-to-drug interactions with MAOIs, multiple prescribed and over-the-counter medications can be potentially lethal. So you can't even take cold medications. Serotonin syndrome with SSRIs and many others. So you got to be really careful of what you're taking in. Available formulations, Nardil, Marplan, and Parnate. Similar medications, Eldepril, Selaginine. Selaginine is used to treat Parkinson's symptoms. It's a selective B inhibitor at low doses, so restrictions are not critical. At higher doses, it acts as a typical MAOI, and so there is a need for restrictions. Recently available as a transdermal patch, as we said before, MSAM, to treat depression and not needing food restrictions at low dose, although still drug interactions that you have to be careful of. It's reversible selective A inhibitors not available in the United States, and there are no restrictions. So what are we talking about? We're talking about Europe and Canada. Okay, now we're going to talk about mood stabilizers. These are the medications that we give to people who are suffering from bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used as a treatment of acute mania and prophylaxis to keep people from getting going into acute mania and, of course, depression. Prophylaxis is a medical term. It means to keep something from happening. When I was young, we used to call condoms prophylactics because they kept you from getting sexually transmitted infection. So anytime you see the word prophylactic or prophylaxis, they're not talking about condoms. They're probably talking about keeping you from getting something else, some other problem. Lithium carbamazepine and valproic acid. Lithium was recognized as an anti-manic drug in 1949. Lithium toxicity identified after being used as a substitute for sodium in salt. So they thought they would, as brilliant as people are, they decided you can make salt out of lithium. Instead of sodium chloride, it's lithium chloride. And they decided to make a salt out of this stuff. And just give it to everybody. Let everybody use lithium chloride as their salt. It tastes just like sodium chloride. So why not? And you would have a more controlled society. There would be fewer manic people out there. But what happened was, as we discovered, if lithium is a heavy metal, and it builds up in your tissue, and that's the toxicity that they were talking about. When people are on lithium to control their bipolar disorder, one of the things you have to do is draw their blood every month to make sure they're not they're not building up too toxic a level in their system. In 1966, French researchers demonstrate valproate's efficacy in treating mania. In 1970, the only thing we had to treat bipolar disorder before was lithium carbonate. So we stopped but then in 1966, valproate, which is an anti-seizure medication, was discovered to stop mania as well. 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. 1980s, studies demonstrate effectiveness of carbamazepine in bipolar disorder. Carbamazepine is an anti-seizure medication as well. So this is all happening. I started in medicine in 1971. So this is all happening. Most of this is happening while I am. That we are discovering all these things while I'm working in medicine. So I'm coming in contact with it. The lithium, of course, because we have to draw lithium levels on people, and the tricyclics. We have to draw drug levels on those guys as well. And we had to develop ways of measuring the heavy metals. What did we use? What was we had a special machine. I can't think of the name of it right off the top of my head. I'm having memory problems. Lithium features. Lithium is the only mood stabilizer without significant anticonvulsant properties. It's up to 70% response rate. Lithium has demonstrated effectiveness in reducing suicidality, less effective in rapid cycling and mixed bipolar states. Full clinical effect may take up to 1 to 2 months. In other words, you start taking lithium and it doesn't really build up enough in your system in order to take away your mania for about for between 4 to 8 weeks. Serum levels guide dosing. It's excreted through your kidneys. It is a heavy metal. Minimal liver mediated drug to drug interactions, so it can build up in your liver. Side effects of lithium: fine tremors, weight gain, nausea, increased thirst, and urination. More severe toxicities include coarse tremor, gait instability, vomiting, diarrhea, and confusions. So if someone is on lithium, this is one of the things we watch for. Sure, they've got a little bit of a shake in their hands, but if they have if that shake becomes a more severe tremor, then we know that we're poisoning them with the lithium. Increased risk of toxicity with fluid or salt restriction, hot weather sweating, use of anti-inflammatory drugs, ACE inhibitors and angiotensin receptor blockers, and diuretics. Why do these things cause a problem? Because they take fluid out of your system, and that's of course what's happening. We know that we are doing a good job if we don't have any of these symptoms. If we do, it may not be because we're giving them too much. It may be because they're exercising and sweating effusively or whatever, or they're taking a diuretic, or they're taking an ACE inhibitor, or they're taking an anti-inflammatory drug, which sucks the fluid out of your system. So you've got to be aware of what's going on. You can't just be aware of what they're taking and pretending that everything is equal. You've got to be aware of the weather. You got to be aware of what other the infection they have in their foot. You have to be aware of the fact that they have hypertension and they're using an ACE inhibitor. You got to be aware of all of this stuff. They may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of the kidney functions, creatinine and BUN, blood urea nitrogen. Those are kidney functions. And TSH. TSH stands for thyroid stimulating hormone. It's one of the things that we measure if we think someone's having thyroid problems, and if we think they have a kidney problem, then we'll do their creatinine and their blood urea nitrogen to determine um, if they have too much of this stuff in their system. If they have too much, then we know that their kidneys aren't functioning properly and their thyroid isn't functioning properly. Females are at much greater risk of lithium-related thyroid dysfunction. Um, because your metabolism is different from males. Males have a faster metabolism, but females have a slower metabolism, and for that reason, they can have greater interaction between their thyroid and the lithium. Carbamazepine is also called Tegretol. It's used as an acute mania and bipolar maintenance. It's an anti-seizure medication. And the first time I came in contact with this was before we started using it in the United States. Remember, it said in 1966 the French discovered that valproate, which we're going to talk about next, reduced mania. Well, yeah, that happened in France, but we were kind of pissed off at the French at that time. Um, and we didn't always listen to everything that they said. So it wasn't until the middle 70s that we started using carbamazepine to control bipolar disorder as well. And the reason is because, we were not happy with the French. As stupid as that sounds, there are other things that we did to ignore the French, even though they had made yeah, they had made these amazing discoveries. We just kind of ignored it because we're Americans, so we only accept what we accept. As stupid as that sounds. One of them was Piaget. I know you've heard about Piaget from developmental psychology. We ignored Piaget for the longest time. He wrote in French, and because he wrote in French, we were able to ignore everything that he said because we are Americans and we don't play that game with the French. We did the same thing with the Russians, but the Russians were more our enemies than the French were, certainly. As stupid as all that sounds. Politics gets involved in medicine. Isn't that stupid? Okay, we're talking about carbamazepine or Tegretol. It's used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. It's less effective in bipolar-related depression. Serum levels can be helpful in guiding dosing. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing carbamazepine, of course, and increasing carbamazepine because of other medications. It induces its own metabolism, so it may need to adjust the dose over several weeks. Okay, so why in the world did I come in contact with carbamazepine and valproic acid? The reason is because, or valproate is another way of saying valproic acid, is because we had people with epilepsy and they were taking these medications, and we had to draw drug levels on these individuals to make sure that it wasn't becoming toxic in their systems. Side effects of carbamazepine, gastrointestinal problems, nausea, constipation, diarrhea, appetite loss. Central nervous system, it's a bit sedating. It causes dizziness, unsteadiness, and confusion. Benign rashes are common, but catastrophic rashes are rare. Many possible serious abnormalities in your complete blood count, which includes the white cell count, the red cell count, and the platelet count. And one of the things it may reduce your sodium levels, which is called hyponatremia. Hyponatremia can kill you if you reduce sodium levels because that makes the neurons in your body less functional. If this is happening in your brain, you may have a psychotic episode. I came across an individual who was drinking excessive amounts of water. So what she was doing was diluting her system with too much water. Now you would think, well, that's not going to make any difference. She'll just pee it out. That's not what was going on. What was happening was she was suffering from hyponatremia, and it was changing the amount of sodium in her system. We need to maintain a salty environment in our bodies. If it is too diluted, then it will cause our neurons to malfunction. And that's what was happening with her in her brain. So she was having psychotic episodes. The mailman would come every day to her house, and he would drop the letters in through the mail slot. And she thought that it was somebody who was coming to attack her. So she got out a pistol, and when he started making noise coming up the steps, she put a couple holes in the door. He hadn't gotten up that high, luckily, and she missed him. But of course, the police were called, and then we got involved. She was a rich lady in town, so nothing happened to her for taking pot shots at the postman. But she was suffering from hyponatremia, and that can happen. Marathoners, if they try to drink too much water. Marathoners don't like to stop at water stops. They want to skip as many as they possibly can. So one of the things they will do is hyperhydrate. Well, when they hyperhydrate, of course, they dilute out their system. They dilute out the sodium, and it can potentially kill them. And that kills more people than heart attacks at marathons. Is hyponatremia. They will have a adverse reaction, and you can't live this way. You got to have a balance. You got to have homeostasis in order to survive, and if you drink too much water, it may potentially be so much water that it kills you, just like alcohol. If you drink too much alcohol, you anesthetize your cerebellum to the extent that and your brain stem to the extent that you can't breathe anymore. You're not breathing anymore. And okay, so everything in moderation, including water. What a surprise to everybody. But if you drink too much water, it's called hyponatremia. Liver function abnormalities are rare but possible with carbamazepine, and that's another thing that we were measuring was their liver functions, their liver enzymes. Toxic metabolite, 10 to 11 carbamazepine epoxide, can create problems via drug-to-drug interactions, especially with valproate or valproic acid, as I was calling it before, lamotrigine and phenobarbital, independent of carbamazepine levels, and it can be checked separately. All of these drug levels have to be drawn. Lamotrigine, we're going to talk about. It's another anti-seizure medication. Phenobarbital is a benzodiazepine, and valproic acid is an anti-seizure medication. We're going to talk about all of those. Valproic acid or valproate or Depakote features, it can be dosed rapidly to treat acute mania. It is more effective than lithium at rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and others in other psychiatric disorders. It is approved for migraine prophylaxis. Its serum levels can be helpful in guiding dosing. That's my job. That was my job when I was a lab tech. It was drawing blood for drug serum levels, valproic acid levels. Commonly used at top or above levels stated for seizure control. Some suggest supplementation with carnitine, selenium, and others to reduce side effects. Side effects of valproic acid, nausea, weight gain, unsteadiness, that's also known as ataxia, hair loss and tremors, liver dysfunction, decreased platelets, thrombocytopenia, pancreatitis, rare but potentially serious. Pancreatitis is an infection, is an abscess in your pancreas. Not good. It's not good. You need your pancreas. That's where your insulin comes from, and that's where your digestive juices come from. Polycystic ovary disease is suggested by some reports. And this, of course, is for women. Ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. I've been calling it an anti-seizure medicine. I should have been calling it an anticonvulsant. Lamotrigine, carbazepine, and topramate. These are the newer mood stabilizers. These are the newer anticonvulsants. Lamotrigine is the only thing that I've come in contact with. The rest of this stuff is so new that I have never seen it before. 1990s, lamotrigine investigated for mood stabilizing properties after patients on it for seizure disorder report benefits. 1990s, most newer approved anticonvulsants are investigated for mood stabilizing properties. Lamotrigine approved for bipolar 1 maintenance in 2003. Lamotrigine or Lamictal is minimally sedating, unlike most other mood stabilizers. It appears to, and that's one of the problems with people with bipolar disorder. They hate to take their medication because it makes them feel dull. It makes them feel sedated. So they'll go off of it, and all of a sudden they're feeling this burst of energy. You know, you can call it mania if you want, but they like it. It's kind of like being on methamphetamines. It appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children, it's raised concerns about potentially life-threatening rashes, and this is known as Stevens-Johnson syndrome. It's a toxic epidural necrolysis. Real serious stuff. Necrolysis has to do with dying, your skin dying. Not a good, the rash is pretty bad. I've seen it before, but not with I don't think they had epilepsy. I used to work in a children's hospital in Omaha, and I saw a lot of some really serious stuff, including cancers. We had a cancer center for children. That was not a happy place. Initiating lamotrigine is done very slowly to decrease rash risk. Valproate greatly increases lamotrigine levels. Carbamazepine greatly decreases lamotrigine levels. The fact that I was really good at drawing blood, that was good, because a lot of these kids had other things to think about. They certainly didn't need to think about how painful a blood draw was going to be. So, you know, you got to deal with what you got to deal with. And I was working in a children's hospital, so, you know, that's just the way it works. Somebody had to do it, and it was a good thing that I was so good at it, because I didn't cause, and I usually got my blood, and I caused minimal pain. So that's what you need if you're going to work in a children's hospital. Carbazepine, trileptal, is used primarily in combination with other mood stabilizers, although efficacy is not clearly substantiated. It's modified carbamazepine with potentially less side effects and drug-to-drug interactions than carbamazepine. 1011 carbamazepine epoxide is not a metabolite, so higher doses required if switching from carbamazepine. Topramate or Topamax is the research questions its use as a mood stabilizer, although scattered reports suggest possible benefit: weight loss, cognitive dulling, kidney stones, metabolic acidosis. These are the newer mood stabilizers. Keppra. Efficacy in bipolar disorder is unsubstantiated, although scattered reports suggest possible benefit. Minimal drug-to-drug interactions. Zonegran, efficacy in bipolar disorder is unsubstantiated, although scattered reports suggest possible benefits. Side effects similar to topramate, including weight loss. Olanzapine, fluoxetine combinations, Symbyax, is approved to treat bipolar depression. The older antipsychotics, now we're going to talk about the antipsychotics. We talked about bipolar disorder, we talked about depression, now we're going to talk about the antipsychotics. In 1950, chlorpromazine was synthesized as a sedating antihistamine. In 1952, chlorpromazine was reported to be beneficial in psychosis and mania. In 1953, the first reports of chlorpromazine associated with movement disorder. 1958, haloperidol was developed. 1962, long-acting injectable fluphenazine was developed. 1970, dopamine hypothesis of schizophrenia was suggested. In 2005, Katie trial shows positive outcome for perfenazine compared to newer antipsychotics. Now, there's a reason why I don't pronounce these words as well as I potentially could. It's because I started my medical career as in the Air Force, and of course, not a whole lot of schizophrenia uh, and schizophrenia treatment. Of course, if you're being treated for schizophrenia, you're not going to stay in the military. They're going to medically board you out. So I didn't come in contact with a lot of schizophrenia while I was in the service. Um, and I didn't come in a lot of contact with schizophrenia out of the service either, because I was working primarily in emergency rooms. Of course, these people would come in from time to time, but we didn't see nearly as much as we saw with the anxiety and the drug interactions, especially the illicit drugs, a lot of depression, a lot of anxiety, methamphetamines, opioid overdoses, that kind of stuff. Not a lot of schizophrenia, though. Neuroleptic means seize the neuron. It refers to the tendency to cause stiffness and other neurologic symptoms. Early methods of dosing would achieve neurolepsis and then back doses down to relieve this effect. In other words, how were they treating these people? They were giving them high doses, and they would give them a high dose until they went into neurolepsis. They would make them, they would cause them to be stiff, they would cause them to have seizures. Then they would back off the dosage because they wanted to give them a dosage that worked for them. So they overdosed them to begin with. As dumb as that sounds, that's the way they used to do it. Major tranquilizer refers to the tendency to sedate, quiet, and create a blandness in patients, similar to the negative symptoms of schizophrenia. Now, you have to remember, in the beginning, we're talking about the 1950s, and before the 1950s, we had no way of treating these individuals. We had no medications to treat these individuals. And then in the 1950s, we were using shock therapy, we were using insulin therapy, we were using thermotherapy, where they'd put them in ice baths and force them to stay in there for an extended length of time until their core body temperature went down, and they would sometimes have seizures. I know this all sounds horrible, but then we developed all of these then we started developing medications, and once we started developing medications, now it's possible that this individual can become a functioning person in society. Before this, they were all in asylums. They were all in insane asylums. This was happening all over the world. If somebody had a psychotic episode, sometimes they would get better and the doctor would let them out. But usually they were staying for an extended length of time. So when we talk about putting them giving them a toxic level of this stuff, yeah, that's because the doctors could do it. They had them there. They were going to keep them there. They knew that they weren't going to leave anytime soon. So it's not like they were afraid that they were going to have a breakdown once they let them out, because that's not what was happening. This is in the 1950s and 1960s. And then in the 1980s, there was a president of the United States that decided that all of these mental hospitals around the United States were too expensive to maintain. So he opened them all up. By that time, we had better treatments, and we were able to actually let them out. And now these places are empty. I mean, we don't use them anymore. But it's because we have maintenance drugs for almost all of these problems. Okay, so that's the history, and it's not a pretty history. It's an ugly history. So we have to talk about all of these words, all of these terms, all these negative things that we were doing. We were putting them in neurolepsis, and we were tranquilizing them to the point that they were shuffling around. They were so completely sedated. So the major tranquilizers were the ones that we used, the thorazine that we used. This differentiates from the mild or minor tranquilizers, the Valiums that we were using for people that weren't quite as severe. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonist highlights strong dopamine activity and tight binding at D2 receptors. Side effect terminology, extrapyramidal symptoms, pyramidal symptom responsible for voluntary movement, extrapyramidal symptom responsible for involuntary muscle action. It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. You probably have heard of tardive dyskinesia. It's a word that I like to ask people about. Acute dystonia is sustained muscular contraction of neck, eyes, and throat. It generally occurs soon after starting their medication. Akathisia is uncomfortable continuous motor restlessness, shaking or tremors or popping your foot up and down. It can occur anytime in treatment, but generally in the first few weeks after they start taking these medications. It's easily misdiagnosed as underlying psychiatric disorder, akathisia. Parkinsonism is tremor, muscle stiffness, slowed movement, and drooling. Generally occurs beyond 1 week after starting medication. Tardive dyskinesia is spastic facial distortions and tongue movements. Sorry, the dog's barking. It may extend to neck, trunk, and extremities. Delayed effect, usually beyond 6 months from starting medication. Its risk increases with duration of exposure to antipsychotic medications. It's known to occur without antipsychotic therapy. It may be permanent, occur on discontinuation or resolve on its own. It is worsened by medications used to treat other extrapyramidal symptoms. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremor, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities, elevated white blood cell count, and creatine phosphokinase, which is a muscle enzyme. It's also a liver enzyme. We used to measure it when we were looking at people who had had heart attacks. The higher the level, the more damage that was done. The heart is a muscle. It's a smooth muscle, and it has a certain type of creatine phosphokinase that we can measure to determine how much damage was done to the heart. Mortality is 10 to 20% with neuroleptic malignant syndrome. It can occur anytime in course of treatment. It has anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, mydriasis, dilated pupils, mydriasis, sorry. These are the older antipsychotics, methods of classification, clinical effect, and potency. Low potency, chlorpromazine, mesoridazine, thyradazine, medium high sedation, low medium extrapyramidal symptoms, high anticholinergic effects. Medium potency, perfenazine, loxapine, and melindone. This has low, medium sedation, high extrapyramidal symptoms, low, medium anticholinergic effects. The high potency methods of high potency drugs, fluphenazine, trifluoperazine, thiothiazine, haloperidol, and hymaside. Medium low sedation, high extrapyramidal symptoms, low anticholinergic effects. Now you can tell that I haven't really dealt with these types of drugs before. They're very difficult to pronounce from time to time. Anyway, chlorpromazine, also known as thorazine. This is the first one. This is the biggie. It has cardiac risks and weight gain. Fluphenazine, prolixine, has long-acting injection available. Haloperidol or Haldol has long-acting injection available. Loxapine and mesoridazine has cardiac risk. Moban, Trilofan, Orap has cardiac risks. Melaril has high cardiac risk. Navane and Stelazine. I won't try to pronounce the others. Newer antipsychotics. Okay, I've come in contact with some of these. Clozapine was introduced in the United States after a long delay related to safety concerns. That was in 1990. 1994, risperidone was developed. 1996, olanzapine was developed. 1997, quetiapine was developed. 2000, ziprasidone was developed. 2003, aripiprazole was developed. Aripiprazole. 2003. 2004, ADA, APA, consensus report on obesity and diabetes and those taking antipsychotics, which is a problem. If you've ever been around a lot of people with who are taking antipsychotics, their muscle tone is really poor. They tend to be flabby, but it's because of the medication that they're taking. So obesity and diabetes is a real serious problem with these guys. Terminology: atypical antipsychotics, second generation antipsychotics. They're serotonin dopamine antagonists. Mechanism: it adds serotonin 5-HT2A activity. It binds more loosely to dopamine receptors. Clozapine initially was rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of extrapyramidal symptoms. Indications and uses: schizophrenia and other psychotic disorders, acute bipolar mania and maintenance, augmentation of antidepressants and mood stabilizers, aggression and impulsivity. The features: less risk of extrapyramidal symptoms and movement disorders, greater effect on negative symptoms of schizophrenia. Cautions: greater risk of obesity, diabetes, and lipid abnormalities. Clozapine effects, olanzapine effects, quetiapine, risperidone effects, ziprasidone, and aripiprazole. It requires regular monitoring of metabolic parameters. It has potential stroke mortality risk in the elderly. Why is that? Because of the lipid abnormalities. Extrapyramidal symptoms, movement disorders, and NMS all can still occur, although much less than typical antipsychotics. Aripiprazole is also known as Abilify. You've probably seen commercials on television about Abilify. Its unique complex mechanism: it can be either activating or sedating. Nausea is common with Abilify. Clozapine or Clozaril, most effective antipsychotic. It has a risk of agranulocytosis. That means it decreases your neutrophils, and your neutrophils are one of your white blood cells, one type of anti white blood cells. They're the ones that fight bacteria. So this is a real problem. Can be a problem, infection with Clozaril. CBC weekly for 6 months, biweekly for 6 months, and then monthly to make sure your neutrophils haven't tanked. Multiple other, and these are running through your body all the time. You've got bacteria entering your body all the time. It's just, and viruses, they're there, and there's nothing you can do. They're in the environment. So in order to be healthy, one of the things you need to do is have circulating neutrophils and and monocytes. You need these lymphocytes. I'm sorry, lymphocytes in your system to capture the viruses and bacteria. They have to be there, and otherwise you'll get uh, multiple bacterial or viral infections. Those of us with lots of lymphocytes in our system, we don't get viruses. We don't get the flu. We don't get other problems. I know we're weirdos. We don't catch colds. But I mean, that's what you need. You need that. That's the type of immunity that you need. Since I was a lab tech and came in contact with lots and lots of different diseases, I'm fairly immune to just about everything. I was a little afraid of the coronavirus because I had come in contact with it, but it wasn't COVID-19. So I thought maybe I would get it, but I didn't. So I guess I'm lucky. I'm not lucky. I've got a good immune system. So that's just the way it works. Multiple other side effects and drug interactions that we don't talk about. Levels are reduced by smoking, so you can't smoke, which is one of the things that if you've ever been around schizophrenics, they are chain smokers. That's because it increases the dopamine level in their brains, and that controls their psychosis. So they tend to smoke a lot. Olanzapine, Zyprexa, Zydus, significant weight, diabetes, and lipid abnormality risk with this stuff. The levels are also reduced by smoking. Quetiapine or Seroquel, its approved dose range considered low by many, low extrapyramidal syndrome risk. It's used commonly as a sedating agent. Quetiapine. Risperidone or Risperidol, this is one that's real popular, real famous. Most like the typical antipsychotics at higher doses. It's available in long-acting injection called Consta. Zyprasidone, Geodon is approved for dose range considered low by many. Its initial cardiac concerns appear insignificant for most. Must be taken with fat-containing meal or snacks. The anticholinergics, what do they do, Artane? What are we talking about here? Oh, anticholinergics. See, we're talking about antipsychotics. Benztropine or Congentin is least sedating, most commonly used. Akinton, Benadryl, Artane, Simitril. They're not an anticholinergic. They're used rarely to treat the extrapyramidal syndrome. It treats extrapyramidal symptoms, tremor, stiffness, drooling, and there's an O in the drooling. Dystonias, akathisia. It may not respond to the anticholinergics. Tardive dyskinesia may worsen with anticholinergics. Dry mouth, constipation, blurred vision. The extrapyramidal symptoms thought to be cholinergic dopamine imbalances. The benzodiazepines, 1957, Librium was developed. That's that's chlordiazepoxide. That was in 1957. Librium. 1970s, Valium, diazepam was a top-selling drug in the United States for an extended length of time. Valium, and then in 1986, Xanax was invented. Alprazolam. It's then became the top-selling drug in the United States. 1990s, SSRIs replaced some of the chronic benzodiazepine used for anxiety. And then Prozac became the top-selling drug in the world. And now, of course, the top-selling drug in the United States and around the world is Viagra. As weird as that may seem. Why does everybody have... And, of course, it only includes... The only people taking it are men. It doesn't work for women. Why do so many men have erectile dysfunction? Benzodiazepines, general characteristics, it differs in action, duration, drug-to-drug interactions, and side effects based on differences in absorption rate, lipid solubility, and metabolism. Indication uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawals, muscle spasms, agitation, catatonia, and akathisia. Hospital use, so you can use it either as intramuscular injection or in an IV. In sedation for procedures, that's usually when you use Valium. Side effects, I needed orthoscopic surgery on my knee. I had a meniscus problem in my knee. I had a buckled meniscus. So I went into surgery and they gave me the Valium. And of course, it's supposed to sedate me. Didn't do anything to me. Didn't make me feel loopy. Didn't do anything to me. I was a little disappointed because I was about to get to have a garden hose stuck in my knee. Not really. It was just a tiny little thing. But it felt like a garden hose. I didn't have any pain. It wasn't a problem. Had the surgery, and of course it didn't work. Or the surgery worked. I had no problem. My knee's fine. Actually, my left knee, that I had all the meniscus taken out of and my ACL trimmed, I have less pain with my left knee than I have with my right knee, which I've never had anything done to. Not important. Side effects, sedation, cognitive impairment, anterograde amnesia. Theoretically, it messes up your short-term memory. Respiratory depression at high doses or with alcohol. It may worsen obstructive sleep apnea symptoms in susceptible individuals. Abuse and dependence. Risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of long-acting agents to minimize between-dose breakthrough and avoiding taken as needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of underlying anxiety disorders. And this is the problem with anti-anxiety medications. Needing to increase a dose, tolerance not generally an issue as at therapeutic doses. But of course, some people are taking them to get high. And if they are, now you got a problem. So we're talking about half-lives. Alprazolam or Xanax is short to mid. Librium is long. Klonopin is mid to long. It's a serotonergic. It has serotonergic properties. Transine is long. Valium is long. Has a long half-life. And for that reason, anything that's long or mid, of course, will stay in your system for an extended length of time, and you need to be careful of it. Valium, diazepam is long. Astazolam is also known as Prosom, is mid. Dalmane is long. Ativan is short to mid, has minimal drug-to-drug interactions. Cirax, short to mid, minimal drug-to-drug interactions. Restoril is mid, it has minimum drug-to-drug interactions. And Halcyon is short. Other anxiolytics and hypnotics. 1969, chloral hydrate was first used. Chloral hydrate is 3 molecules of alcohol stuck together. That's why it knocks you out so fast. 1992, Ambien was approved. 2006, Zolpidem or Ambien was used or became a generic actually. Hypnotics equal medications to induce sleep. Non-benzodiazepine anxiolytics include buspirone and antihistamines, so you can knock yourself out with antihistamines as well. Newer anticonvulsants are used off-label as both anxiolytics and hypnotics, although efficacy is unproven. Trazodone, which is a SNRI, and some tricyclic antidepressants are used as hypnotics. They'll put you to sleep. Newer hypnotics active at GAB1 receptor, except for Rameltion. Other anxiolytics, buspirone or Buspar is a subtle anxiolytic with slow response. Chloral hydrate, Noctec, is a hypnotic, rapid tolerance, toxicity, and overdose. Chloral hydrate was one of the drugs in Marilyn Monroe's system when she committed suicide. Remember, it's three molecules of alcohol, and she took the chloral hydrate with champagne, so she was mixing alcohol with alcohol. Antihistamines, hydroxypine pamoate is Vistaril. Benadryl, of course, is an antihistamine. Anticonvulsants, mildly sedating and calming. Neurontin, Lyrica, and Gabatril. Selective benzodiazepine receptor activity, GAB1 hypnotics. Lunesta is long-term use is approved. It's the one with the butterfly. If you've ever seen the commercial, I haven't seen it lately. But then again, I don't watch very much as much television as I used to, and I don't watch normal or regular television shows. I usually watch something that doesn't have very many commercials. Too many commercials about constipation. Sonata is has a short half-life. Ambien, of course. Melatonin receptor agonist, Razoram, that works as well. The stimulants, ADHD drugs, Ritalin was approved in 1956. 10% of 10-year-old boys in the United States are on some stimulant, ADHD medications. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants, so something that you need to think about. Strattera is a non-stimulant treatment for ADHD. Recent caution about suicidal ideations for these individuals. Rare liver function impairment. Catapres or clonidine is an antihypertensive alpha-2 agonist. It's used for ADHD, substance withdrawal, Tourette's syndrome, and others. Catapres is more common with adults than it is with children. Silert, Pimoline is rarely used stimulant due to liver toxicity. There for a while, Silert was real popular. Dexedrine has multiple long-acting forms. It causes insomnia, headache, tremor, exacerbation of tics, nausea, weight loss, blurred vision, overstimulation. Methylphenidate or Ritalin, there you go, that's the biggie. Same reactions as dextroamphetamine. Modafinil or Provigil is a non-stimulant. It's a poorly understood mechanism of action. They don't know why it works. It's used for sleepiness related to narcolepsy, obstructive sleep apnea, depression, multiple sclerosis. It's used for ADHD, is being investigated. That's Provigil. Medications for dementia. Cognex. So this is the first one in 1993. I was working in a clinic in rural health clinic in Oklahoma when Cognex first came on the market. Wow, it caused a rush coming in to our clinic for people suffering from dementia and Alzheimer's disease. Really kind of interesting because they thought that this was going to cure their Alzheimer's disease. It doesn't. All it does is it arrests it right here, right now. It increases your acetylcholine in your brain, um, but it keeps it at a maintenance level. It doesn't really increase it. It doesn't allow it to decrease, is what it does. But it doesn't work forever. It only works for a short, not a short period of time. It only works for a while, and it really all depends on where the individual is as to how well it works. 1996, Aricept was developed and approved. 1997, generalizability of approval studies was questioned. Namenda in 2003 was approved for moderate to severe Alzheimer's dementia. 2004 detailed British study questions efficacy of cholinesterase inhibitors as far as the medications for dementia are concerned. General characteristics: the search for a treatment for Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. One of the things that is happening today is the fact that the baby boomers are now they're now septuagenarians and octogenarians. They're in their 70s and 80s. They're also in their late 60s. A lot of these individuals are entering dementia, and also they are suffering from Alzheimer's disease. And because there is a larger number, there's a lot more people that were baby boomers than any other generation. Can potentially be a problem. So you guys may have to take care of me in the future because I'll be suffering from Alzheimer's disease. I am a baby boomer. So there you go. Studies that support use of these medications generally find subtle benefit or slowing of decline, and that's usually what we're looking for. There is significant debate about the benefit versus cost. It is expensive, and there are side effects to these medications. Treatment for behavioral issues in dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly, and of course, that seems to accelerate the dementia in the elderly to take antipsychotic medications. But of course, one of the problems that we have in nursing homes is that some of these people become physically aggressive, and so you need to sedate them. The sedation, of course, tends to accelerate the dementia process, sadly. Cholinesterase inhibitors address one theorized mechanism of this complex disease. Aricept, Rimonil, Exelon, Cognex, rarely used due to liver toxicity. This is the stuff that first came on the market. The Cognex, it's not used very much anymore, and that's because it seemed to be accelerating or decreasing the life expectancy of the people that they were treating with it due to liver toxicity. Memantine or Namenda, complex activity via the NMDA, the glutamate mediated receptor. It may have more broad psychiatric applications. Drugs, substance abuse, the use of medications and substance abuse. To treat withdrawal symptoms, benzodiazepines, anticonvulsants, and clonidine. To treat comorbid psychiatric disorders, anxiety and depression are common. SSRIs, mood stabilizers, and benzodiazepines. To prevent relapse, deterrence, and craving control. Disulfiram antabuse is a deterrent. It is required. It requires a motivated patient. Antabuse is a medication that reacts to alcohol, makes the individual throw up. There have been cases where they gave individuals antabuse without their knowledge. It wasn't pretty. It wasn't pretty because the individual sued the doctor who gave usually it was a spouse that was giving them antabuse, and of course they weren't aware of it, and it got real ugly. We had a case when I was in the service. This guy's spouse was giving her husband antabuse because he was spending every night at the NCO club, and a real ugly situation. It got ugly. He sued her. He sued the doctor. He sued the Air Force. Of course, you can't sue the Air Force. It doesn't work that way. The federal government has to agree to be sued, and it didn't work. But he was really upset. The case ended when he died of cirrhosis of the liver. So I was going to become part of that because I had to draw his blood, and we were drawing levels on him, and he didn't know what it was. They called it disulfiram, and he kept asking me what it was for, and I couldn't tell him because the doctor told me not to tell him. This was in Germany. Ugly stuff. Anyway, let's not dwell on the past. Minimal drug-to-drug interactions with camomile. Efficacy shown in some studies with more severe alcoholics, although other studies question its efficacy. Naltrexone Revia is an opioid antagonist. It has a high response for placebo cause. Some of the questions of the study design. Potential liver toxicity. Vivitrol injectable naltrexone lasts for about 30 days. Buprenorphine naloxone is a treatment for opioid dependence. It contains both an antagonist and an agonist. Bupropion or Zyban is identical to Wellbutrin. It treats nicotine craving. Others, several anticonvulsants, topramate, etc., have been used for craving reduction. The uses of these drugs are off-label and carry additional potential side effects from their cardiovascular actions. Potential psychiatric benefits have often been discovered, while these agents were used for their primary indication. Monitoring of blood pressure is necessary with these drugs. Psychiatric uses of antihypertensives, alpha adrenergic agonists, clonidine, guanfacine, prazosin. It's used in ADHD, Tourette syndrome, PTSD. Prazosin found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol, used for akathisia, lithium-induced tremor, performance anxiety, and aggressive behavior, hyperarousal. Pendolol has been considered for antidepressant augmentation, multiple drug-to-drug interactions, to avoid if you have asthma, diabetics on insulin, certain cardiovascular diseases. Calcium channel blockers, diltiazem, verapamil, and nimodipine. It may be helpful as additional agents in bipolar maintenance. Multiple drug-to-drug interactions and precautions. And that's it. We are done. Enjoyed this class. I always enjoy my 360 class. If you have any complaints, any suggestions, I'll be glad to take them. I have office hours Monday and Tuesday in the afternoon, 3 to 5. And in the morning, or on Tuesdays and Thursdays, it's 8 to 10 in the morning. But if you need to contact me about anything, then you can make an appointment, and I'll be glad to turn on my Zoom so that we can see each other, which should be quite entertaining in itself. So I'll see you guys next semester.